Everyone. This is Dan Roper. I'm the medical director of the emergency department, and we are here to present the pulmonary embolism interventional radiology algorithm. And I'm here with Eric Chow.
Hi there. So just to introduce myself a little bit, my name's again Eric Chow. I'm one of the interventional radiologists over at Kent Radiology, and we serve St. Mary's departments and all of your interventional sort of needs. I've been with the group for about 2 years now, and excited to talk a little bit more about PE and what we can offer in this kind of field.
Great. We we've had standard therapy for pulmonary embolism forever, but the standard therapy is starting to change some now for larger pulmonary embolisms, such as saddle pulmonary embolisms or pulmonary embolisms that cause cardiac strain. And I think most of us are aware that if there's hypotension associated with that, we can treat those pulmonary embolisms with systemic thrombolytic therapy. But it's my understanding now that here at St. Mary's, we have some new tools in our toolbox to actually treat these with a mechanical thrombectomy. So why don't you tell me a little bit about the history of that?
Yeah, sure. So we started doing these about 2 years ago, actually pretty shortly after I started. And so the device we use is from the company Inari, and it's called the FlowTriever. Basically, it's a very large bore sort of catheter that we direct into the pulmonary arteries and actually manually sort of suck the clot out of the body. And we've seen very good results in the some that we've done. We've done probably about 20 or so at this point over the course of 2 years. And patients can have pretty dramatic clinical improvement even on the table after this sort of procedure.
Great. I think one of the things we're doing is trying to make sure that all of the ED providers and other providers in the hospital know that this is available, because for patients that qualify for this, this is potentially a great therapy to get them turned around and improve better. So what you have done in order to make this easier for us is you've kind of created this super easy algorithm to follow.
Yeah.
And so I'm gonna share this with everyone here, and we're just gonna kind of talk through this real quick. We're gonna make this available for people in the moment on our SharePoint website. But this algorithm should be really easy to follow and should help people decide when their patient might be a candidate for interventional radiology with pulmonary embolism. So I'll go ahead and share this right now. There we go.
Yeah.
Eric, why don't you tell us about this?
Yeah. So this is kind of tailored to, after you've discovered a PE, whether that, in most cases, that's after a CTA is done, showing that. And, first things first, we always want to start the heparin drip. We also do like to check biomarkers to kind of assess for the cardiac function or dysfunction in this case after a PE is found. And so then we hit our first branch point, which I know Dr. Roper kind of alluded to earlier, which is hypotension requiring pressors or cardiac arrest that might need CPR. Those are really the more massive sort of PEs where, really quickly intervening is the best option. So we're kind of in that massive PE side, that red box over there. So obviously, if we're in-house, please call us right away. We can try to do an emergent thrombectomy. Otherwise, if we're going to take a while or something, I would recommend starting the systemic TPA just so you get some sort of mechanism of action to improve that clot burden as quickly as possible.
Yeah, those are always pretty scary. You got to move pretty fast.
Yeah.
But for everything else, now we've got some new options. So let's say that they're not hypotensive or in cardiac arrest. We find ourselves going to the right side of this algorithm. Tell us a little bit about what we see and what information we might already have from the CT angiogram that we already did to make the diagnosis.
Yeah, so the CT angiogram is actually very useful in kind of assessing for right heart strain. As you are probably aware, the left ventricle should always be larger than the right ventricle because it has to pump into the systemic circulation rather than just the pulmonary. So when we see that the right ventricle is actually larger than the left ventricle on CT, that is a pretty good indicator that there is some evidence of right heart strain and that the heart is working harder than it needs to secondary to this PE. Of course, biomarkers, which I already mentioned, are also another indicator of right heart strain. So if
Great.
all of those are negative, of course, obviously systemic anticoagulation kind of works. But if either of those are positive, that's kind of what we're discussing today on the sort of intermediate or submassive PE side.
Right. And there are some other protocols that kind of define when this might be the appropriate patient. A lot of them use echocardiogram to determine right heart strain, but we very intentionally made that something that isn't necessarily always part of it. There will be certain circumstances where right heart strain or right ventricular enlargement is equivocal on the CAT scan. So in that case, obtaining a stat echo to look for right heart strain is certainly possible, and you can see it mentioned in parenthetically here in this yellow box. But oftentimes that's not necessary because you can see that right on the CAT scan, and that would bring us down into the middle of this algorithm where we either have an elevated troponin or an elevated BNP, or we see right heart strain on the CT scan, and now we are able to differentiate whether this is an intermediate low risk or an intermediate high risk. And that kind of has to do with how many of these risk factors we're looking at. So do we see right ventricular strain and elevated biomarkers, or do we see just one or the other? And that puts us into these two different categories.
Yeah, that's right. So certainly if there's both right ventricular dysfunction and elevated biomarkers, that's a little bit more concerning for us as interventionalists, and we would recommend consulting us at least for potential catheter-directed therapy. In this case, we do pretty much all Inari, the FlowTriever I mentioned, where we suck out the clot. If it's one or the other, they probably could be okay with just systemic anticoagulation. If there are other sort of high-risk clinical factors, things like SPECI or any of these other ones that I've kind of mentioned in the algorithm, it certainly doesn't hurt to give us a call, and we can kind of assess at that point and see if the patient might benefit from a thrombectomy.
Absolutely. And I think one of the take-home points is both the arms of this, whether it's high intermediate or low intermediate, go ahead and call interventional radiology to discuss the case. Depending on what their availability is, time of day, and the specifics of the patient themselves, will help you collaborate with interventional radiology to decide if this is indeed a candidate, if it's something that should go immediately, or if it can wait a little bit. But I think the take-home point is if you're in this category, then call IR, discuss the case, and discuss whether this is potentially a candidate for the Inari FlowTriever clot removal with interventional radiology.
Yeah, that's right.
All right, well, that's it. We want to keep this short and sweet. Hopefully this gives you what you need to know to start treating appropriate patients with clot retrieval. And if you have any questions, go ahead and email them to me or to Eric, or just find us any way you can.
Yeah.
That's it.
All right.
Thanks,
Thank
everyone.
you.